Hi, Ellen Liu. I'm one of the interventionalists at Ohio State. Thank you for having me today. Today I wanted to review STEMI recognition. No disclosure. So I like talking about cases. So I'm going to start with a couple of cases. This was a 86-year-old female who had presented with chest pain and an elevated troponin. This was her initial EKG. There wasn't any glaring ST elevations. There's some changes in V3 over here. You can maybe point out some ST depression in V2. She was having ongoing chest pain with a rising troponin, so I brought her urgently to the cath lab. This was the first shot I took of her left coronary system. The arrow is pointing. I'm trying to point out the left circumflex there is 100% occluded. There's some dye hang up right there. So she was having a STEMI. It wasn't 100% obvious on EKG, but I put 2 stents in, restored flow. So this circumflex artery supplying the lateral wall and the posterior wall of the heart. This is a patient who I took care of at OSU East. She's a 65-year-old female, presented with an out-of-hospital arrest. She was at home, had a single pole episode. Had a single pole episode at home. Family members started CPR, EMS arrived, resuscitated her. This was her first EKG when she got to the hospital. There's a little bit of artifact here, but again, nothing very apparent. Again, there's some ST depression, and you might, pick up some depression there. But her troponin was elevated. We brought her to the cath lab. She also had a left circumflex occlusion. There, she was starting to develop some flow again, but that flow down the left circumflex artery in the OM is very slow. We put 1 stent in and reestablished flow to the lateral and posterior part of the wall. And finally, this was a 61-year-old female who presented with shortness of breath and elevated troponin. There's a lot of artifact here in the beginning, but you notice there's a little bit of a pause. She was going in and out of heart block. And here she has some more prominent depression in V2, but no apparent ST elevation. So we also, if you haven't noticed a trend already, her circumflex was also occluded. She was having a STEMI. She had 1 stent placed with restoration of flow. So the point of those 3 cases are that sometimes patients are having STEMIs. It's not very apparent. How can we improve our recognition of patients who are having STEMIs? So I wanted to review some STEMI statistics up to 2025 guidelines, briefly review coronary anatomy and some correlating ST changes, compare the 12-lead versus 15-lead EKG, and finally I'll end with a couple of additional cases. In the U.S., someone is having an MI every 40 seconds. It's estimated the annual incidence is about 800,000 cases. Over the last few decades, there has been an overall decrease in STEMI incidence. Why do we care about recognizing STEMIs and treating them quickly? STEMIs can present with cardiac arrest or cause cardiac arrest, can cause heart failure, cardiogenic shock. Inferior STEMIs can cause heart block as well. Untreated or delayed STEMIs can eventually lead to mechanical complications such as ventricular septal defects, papillary muscle rupture, ventricular rupture. Recently, some of our societies put together an updated guideline on the management of patients who have acute coronary syndromes. I wanted to focus on Section 3 because it's relevant to how we initially respond and manage to ACS. So the first recommendation is that a 12-lead EKG should be acquired and interpreted within 10 minutes of first medical contact to identify patients with potential STEMI. If your first EKG is non-diagnostic, the recommendation is to obtain serial EKGs to detect potential evolving changes. And it's been shown that a second or third EKG during EMS transport may identify up to 15% of additional STEMI cases that are not seen on the first EKG. And the posterior leads are particularly helpful, V7 through 9, and it should be applied in patients who have ongoing symptoms, who you think are having a STEMI, but the first EKG is non-diagnostic. And also, if you notice some depression in V1 through 3, getting the posterior leads is also helpful to potentially diagnose the posterior STEMI. Immediate EMS transport to a PCI-capable hospital for primary PCI, percutaneous coronary intervention, is the recommended triage strategy. First medical contact to first device time, goal of less than 90 minutes. And the reason we emphasize this is that patients who are managed with PCI for each 30 minutes of delay is associated with a relative 1-year mortality of 7.5%. And finally, advanced notification of the receiving hospital by EMS personnel and activation of the cath lab is recommended to reduce time to reperfusion. And this pre-hospital activation has been associated with lower short and long-term mortality in patients who have STEMIs. Briefly, the anatomy of the heart. So the heart is supplied by 3 major coronary arteries. The right coronary artery supplies the inferior portion of the left ventricle. The marginal branch here that comes off the right coronary will supply the right ventricle. The left main coronary artery branches into the circumflex artery with the OM branches that supplies the lateral and the posterior part of the left ventricle. And the LAD that comes down the anterior wall and goes around the apex supplies the anterior septal and the apical portions of the left heart. This is kind of a busy diagram, but I wanted to correlate the coronary distribution with the leads and what you should see on EKG. So this right coronary artery that supplies the inferior portion of the walls represented by these green leads, so 2, 3, and AVF. So if they are having an RCA STEMI, you should see elevation here in the inferior leads. Next, the lateral leads, 1 AVL and V4 and 5 represent the lateral and posterior portion, potentially the posterior portion of the heart, but usually that's represented by the circumflex artery, or if there's a large diagonal branch coming off the LAD, you might see elevation in 1 AVL and V4 and V5. And then finally, the LAD comes down the front side of the heart, represented by these blue leads, V2, 3, 4. You should see elevation. Oftentimes you'll see V1 through 4 elevation when someone's having an LAD STEMI. So first and foremost, when you see patients in the field, the most important thing is to get a good EKG, because we can't diagnose a STEMI unless there's a good EKG. And obviously, depending on the clinical scenario, that can be challenging. Patients may not always cooperate. They may not always be in the perfect situation. But ideally, if you can get them in a supine position, relax, limbs uncrossed to get a good EKG. Skin preparation is really important, getting the leads to stick properly on their skin. Now that can be challenging because if they're having an MI, they're sweaty, they're uncomfortable, so that can be difficult. But if you can get dry skin, they're hairy, shave them, get the pads to really stick on, get a good EKG, and obviously proper lead placement is crucial. I'll briefly review this. But essentially a majority, you have your, in your standard 12 lead EKG, you have your 4 limb leads, both arms, both legs, and then the 6 precordial leads. So these leads will mostly go in intercostal, in the 4th and 5th intercostal spaces. So V1 will be in the 4th intercostal space to the right of the sternal border, V2 left 4th intercostal space. V4, 5, and 6 should be in the 5th intercostal space at the mid-clavicular, anterior axillary, and mid-axillary lines. And then V3 is just placed somewhere between V2 and 4. When you're getting a posterior, putting the posterior leads on for a 15-lead EKG, V7, 8, and 9 will be on the left back and in the same plane as V6. So V7 will be at the posterior axillary line. V8 at the left scapula, and V9 parasternal. Sorry, paraspinal. Yeah, it'll be in the same line as where V6 should be. So it should be kind of wrapping around in that same plane. The right-sided leads are essentially a mirror image of a standard EKG. And what you sometimes can do is take lead 4, V4, and put it on the right side. And this can sometimes help you support a diagnosis of inferior STEMI if it is involving that right marginal branch and causing right ventricular infarct. This is also, on a separate note, can be relevant for patients who have situs inversus, their heart's on the right side of the chest instead of the left. So once you get your EKG, how do you diagnose the STEMI? So per the guidelines, the criteria for STEMI diagnosis is you measure from the J point here, and it's presumed new ST elevation that is at least 1 millimeter elevation in at least 2 anatomically contiguous leads. So if it's like an isolated elevation in 3, that doesn't really count. It really should be 2, 3, or 3 AVS, something that suggests a coronary distribution. For the anterior leads, the criteria is a slightly higher elevation, and that'll depend on your gender and age as well. Some other things to note: if you do have some depression in V1 through 3, that can suggest posterior injury. And when you have isolated elevation in AVR, but with diffuse ST depression in the other leads, that can suggest a left main or proximal LAD occlusion. I won't go, this I'm not going to go in detail, but there's other causes of ST elevation that can be confusing sometimes. So pericarditis can cause more of a diffuse ST elevation. Paced rhythms and left bundle branch block can be challenging. Those can both cause ST elevation as well. Early repolarization and Brugada syndrome. So when are these additional leads helpful? When there's no obvious ST elevation, but you have a very high clinical suspicion. And really, it's a lot of the times posterior MIs are missed on the standard 12-lead EKG, so having those additional posterior leads are helpful in this case. And the right V4R lead can be very helpful in helping to support a diagnosis of RV infarction. It's kind of rare to have an isolated RV infarct. Usually, it's in the usually you'll see it in the setting of an inferior STEMI, but the right-sided lead can be helpful to help diagnose that. And so this is a patient I got called about recently. She's a 62-year-old female, very sick in the MICU. The team noticed that she had these evolving EKG changes, specifically in V2 and 3, these ST depressions here. And so historically, what we would do is take the paper EKG and basically just flip it over. And that's when you would see elevation in V2 and 3, and that's when you can say that someone's possibly having a posterior MI. And so this is just an example. This patient is having depression in V2 and V3. On the standard 12-lead EKG, and a 15-lead EKG was obtained. So V7, 8, and 9 here, you can see the ST elevation there, and that just confirms your diagnosis. Right ventricular infarct, again, it usually correlates with an inferior STEMI, so you see elevation in 2, 3, and AVF. The team here moved V4 over to the right side of the chest, and there you can see elevation of V4. All right, so that's kind of the bulk of my talk. I just wanted to reveal a couple of cases. These were both field-activated STEMI alerts that I had taken care of. So this patient was 65 years old, had chest pain, called EMS, EKG. You can see elevation here in 1 and AVL. When he got to the hospital, a repeat EKG sort of confirmed this. So when you see this, you start thinking about, is this a circumflex STEMI? Is it a large diagonal branch? So this was our initial image. This is the LED coming down the front. And then you can kind of see some dye hanged up here. So there's a diagonal branch that's coming off the LED that's completely occluded. This is after we fixed that branch. You can see it's a decent sized diagonal branch coming down that was causing the symptoms. In this case, I wanted to emphasize how important it can be to repeat the EKG. So this patient's 51 at home having severe chest pain, called EMS. The initial EKG, you can start to see some elevation here in the anterior leads, and within like 5 minutes, a repeat EKG was obtained. He had a VF arrest en route to the hospital. And here on the second EKG, you'll see a remarkably significantly more increased elevation in V1 through 4, which confirmed the diagnosis. We've got Rosk, and he already reestablished flow down his LED, but there is a large clot here in the proximal LED. That likely was the reason he had chest pain and arrested. And then we went ahead and stented that LED. All right. So take-home messages, a good quality EKG is important. It's the first step in diagnosing an MI. That involves proper lead placement, good skin preparation, an optimal setting, all of which is not, ideal 100% of the time. If you don't catch the STEMI on the first EKG, it's important to repeat the EKG to help diagnose any evolving STEMIs. And the additional leads are particularly helpful for diagnosing posterior STEMIs, and they can support the diagnosis of an RV infarct for inferior STEMIs. And finally, getting a faster diagnosis is crucial in getting the patient the care they need and the treatment they need. And studies have shown that treating STEMIs quicker will lower patients' long-term morbidity and mortality. All right, thank you. That's all I have.